Okay, thank you. Hello, Dan. Welcome. We just starting the meeting now, and you, Dan, will be given the chance to have your presentation, talk about your services. But we will start with Megan Willoughby from Talk Changes first, if that's okay. Are you okay to start, Megan?
Yeah, no problem at all.
Excellent.
Hi everyone. So my name is Megan. I'm one of the senior psychological wellbeing practitioners at Talk Changes, which is the City and Hackney improved access to psychological therapy service. This essentially means that we're a primary care service, so we're usually people's sort of first point of communication or access to mental health services. IAPT was a national programme which was set out to improve access to talking therapies. IAPT services provide psychological support for people experiencing mild to moderate symptoms of anxiety or depression. In terms of kind of provision, so for treatment, we offer a mix of group, one-to-one, telephone, face-to-face and online support. We're a free NHS service and we're part of the Homerton Hospital NHS Trust. In terms of kind of presentations that we treat, just a bit more specifically, so obviously I already mentioned depression and anxiety. We're also able to support people who are experiencing panic attacks, OCD, health anxiety, PTSD, social anxiety, stress, and we can also support with people experiencing anxiety or low mood, but in the context of maybe kind of a physical long-term health condition. In terms of how sessions work, so we are a cognitive behavioural therapy service, and we offer talking therapy based on CBT. This means we support people to learn techniques to improve how they're feeling, to learn new ways of coping. This usually looks like weekly or fortnightly sessions and does involve kind of homework-based tasks, which is essentially sort of implementing what people have learned in the sessions into their everyday life to then review with their therapist as part of the session. CBT is a very sort of structured and practical approach to therapy, and it's sort of very goal orientated as well, so supporting people towards specific goals that they would lay out in their first treatment session with their therapist. We offer a mixture of CBT informed treatment. The first is low intensity treatment. This is something called guided self-help, and this would usually be on average sort of 4 to 6 sessions, and they're about half an hour each. We also offer online.
I'm sorry, Megan. I appreciate that, you know, there is jargon that we all used to hear, but maybe you can describe what CBT is or any other abbreviations that you use.
No problem. So I think we touched on it in the last slide. So cognitive behavioural therapy is just kind of the structured approach, and it's sort of goal orientated, focused around providing people with sort of tools to manage their symptoms of anxiety or depression. I hope that makes sense, but let me know if you have any questions. In terms of kind of the different types of support, just to go back to that, we do have a package called Silver Cloud, and this is just an online program, but it's all informed by the same kind of evidence that CBT is based on. We have the higher intensity cognitive behavioural therapy, and this is sort of 10 to 12 sessions. It basically means that there's kind of extended time and often a bit more complexity around people accessing that type of therapy. We also have groups, and a lot of our role as well is signposting to services in the local area. So cognitive behavioural therapy is going to be kind of right for everyone. So a lot of what we do is thinking about there might be better services to support someone's needs, so we might refer or signpost them to a more appropriate service. For example, it could be somebody's after more of a counselling approach, so they want a more open space to talk through or process things that are going on for them. So then we would look at kind of directing them on to that service. In terms of waiting time, so we start with an initial assessment, and that will usually happen within a week of referring to the service. The waiting times for treatment does depend on what kind of treatment plan is decided will be most appropriate. At the moment, for the low intensity treatment, we're sort of direct booking. This basically just means that the person will be booked into the next available appointment after their assessment. So usually looking at starting their treatment kind of 3 to 4 weeks after the assessment. The wait for the higher intensity therapy is a bit longer, so probably, to be realistic, around sort of 8 to 12 weeks. But we do try to put plans in place of things that people can do whilst they're waiting, and one of those options could be the Silver Cloud online platform, so having access to that. To give you a bit of an idea about some CBT tools that we might teach people, so it can be things like helping people to challenge their thoughts, testing out any beliefs or predictions they have, behavioural activation, so supporting people to kind of gradually increase or balance their activities, problem solving, relaxation, and some lifestyle support as well. I mentioned earlier we do work very closely with an employment service, which is also part of the Homerton. So as part of our service, you can also be referred for some employment advice. They offer a wide range of support, so things like CV workshops, application support, interview preparation, and also kind of job retention. So they can support and attend any meetings or help put people in touch with unions if there are any grievances at work as well. Just to briefly touch on our exclusion criteria, so who would maybe not be appropriate for talk changes. So at the moment, we can only see people who are over the age of 18. We are developing a pathway which will hopefully look at taking people who are age 16 to 17 as well. We can't see anyone that's open to secondary care or any other mental health service. And you have to be registered with a City and Hackney GP to access the service as well. I do have a full list of the GPs we cover, which I'll get emailed around. Other things that might make somebody unsuitable for talk changes would be kind of alcohol or substance misuse, or if they're a high risk of harm to themselves or others around them. In terms of how to refer, so this can be done by contacting a GP or through another professional referral. There's a referral form that professionals have, which they would email directly to our service to then kind of complete that referral process. People can also self-refer by visiting our website and completing a self-referral form, or they can give our admin team a ring as well, and we can take the referral over the phone. I think that's it from me today. Did anyone have any questions at this point at all?
Thank you, Margaret. I can't see any raising hands, but I would have a question.
Yeah.
Is talk changes available in other languages but English?
Yes, we do have kind of provision to provide interpreters for both the assessment and treatment. We have kind of an in-house advocacy service, so that can be arranged quite easily. And
that wouldn't delay the service provision or the first assessment?
No, it wouldn't.
And you be able to tell us, like, I don't know, the first 5 languages that you will provide language support to? What are the main languages?
I think we could cover anything really. It's through an advocacy service, so it does depend on their availability, but we would just kind of work with them to get the person what they need as soon as possible. So we try to avoid it delaying that person accessing support. Perfect.
Thank you. Any more questions for Margaret? For Megan, sorry, Megan.
It's okay.
No? Well, Megan, thank you. Very useful information, really. It will be great if you can send me the slides with some additional information so I can include this in my post-event information to all who are joining today and those who will look at that on our website to find this information. So thank you very much. Thank you.
That's fine. I'll send around everything. Thank you.
And I'll come back to you if there are any outstanding questions for talk changes. Thank you.
Perfect. Thank you.
Now I'll invite our second speaker, Dr. Olivier Andleur. I hope I pronounced his surname correct. Shall I let you introduce yourself and and talk about, again, the mental health support, what is actually mental health, and what are the symptoms of mental illness. Thank you.
Thank you very much. Thank you very much, Kanaya. You did pronounce my name very well. I'm Olivier and Laura. I'm the interim clinical director for adult mental health services in City in Hackney in East London NHS Foundation Trust. So thanks very much for having me this afternoon and inviting me. I will share my slides, if you can. I think you should be able to see them, yeah. So when we prepared with Kanaya, thinking a bit about what could be helpful to present this afternoon in the time we have, 15-20 minutes, what we thought would be to, as Kanaya said, just a bit awareness about mental illness, where and how to ask for help, and then obviously what support is available, and something that relates a bit to the question that Kanaya was asking Megan, which is questions around accessibility. So I'm sure, as Kanaya had said already, don't hesitate to raise your hand or ask a question in the chat, and I'll try my best to answer. And if that's something I cannot answer right now, I'll make sure I pass the answer to Kanaya afterwards, once I got the relevant information. So starting with awareness about mental illness, that, well, in itself, that could be hours of presentation. So obviously it's about finding what could be the relevant part to present to you this afternoon. One way to kind of think about it is thinking, and it's because it has a consequence of how you would access care, is the distinction between what we call common mental illness and severe mental illness. Now, obviously, like any diagnosis or distinction, there are lots of limitations to this distinction, but it's just to help us think, I guess, more than anything else. And so under what we could call common mental illness would be generally diagnosis of anxiety and depression. So anxiety, or what could be called anxiety disorders, are obviously characterized by intense anxiety, and then you will have a range of subtypes of anxiety disorder, such as some are part almost of common language for some people. If you talk about OCD, a lot of people would know what OCD means, being very organized, but when it becomes to a disorder, it's characterized by compulsion. So the need to perform certain actions or to have certain thoughts, having intrusive thoughts that are your thoughts, but imposed by yourself. I need to count to 3, otherwise something terrible will happen. For example, this kind of ruminations and obsessions that can come. So obviously, whilst being organized, or if I lock the door, and checking that you've locked the door is perfectly part of normal human behavior. Obviously, that's in no way a mental illness. When it comes to the intensity and the proportion and the time it takes, you can imagine if you have to do that 25 times, even if you're halfway through on your way to work or visiting someone, and you have to come back because you're so anxious that you haven't locked the door, and then you come back again and again, and you're 3 hours late for the appointment you had or the meeting you had, then you can see that it starts to take a different color and a different impact on people's life, and obviously that can generate a lot of suffering. In addition to that, it's underlined by a lot of anxiety as well. It's quite stressful to have these thoughts, and now, should I come back? Should I come back? So that's just a very tiny example of how anxiety obviously is part of life, and is absolutely, most of the time, something that's absolutely something that can be useful to life. At the same time, it can have some negative consequences. And when the intensity, the frequency, and the impact starts to be significant, that's when then it might be it probably is worth asking for help. So I use this example of obsession, of obsessive compulsive disorder, but there's a range of other anxiety difficulties, such as phobias, like very specific phobias. So that's the fear, intense fear of an object or a situation that would lead people to avoid that situation, to avoid the anxiety, or generalized anxiety disorder, which would be when people are anxious for a lot of things in their life. And again, the intensity, the frequency, the degree, the impact on life would be quite significant. So that's one of the disorder that we would put under common mental illness. Alongside, there's also depression, which most people would have a sense of what depression is, but I guess depression would require help, or clinical depression, if you want, would be when, again, sadness is an emotion. It's a human emotion. It's perfectly part of life, and there's nothing wrong with being sad. This is not a pleasant feeling, but this is part of the human emotions. When the sadness becomes very frequent or consistent, and most days and most times of the day, and you start even losing sight of why you have this feeling of sadness, you just feel sad, or lack of pleasure of what you usually would enjoy, suddenly everything starts to lose the taste, the salt of life, the enjoyment of doing things. Again, we can all have a few days where we don't feel fantastic, but when it becomes consistent, intense, and so on, then that starts to become something where you might want to think, oh, maybe I'm a bit depressed. So that's two examples of what we would call common mental illness. In no means is it absolutely exhaustive and represent the whole spectrum, but that's a couple of examples. And next to that, if you want, what we could see more typically would be called severe mental illness. It's not that anxiety or depression cannot be severe. It's just a way of looking at things. And typically, for example, in severe mental illness, you would have psychosis. One of the forms of psychosis is called schizophrenia. And psychosis would be more characterized by having difficulties with, for example, unusual experiences, such as hearing voices when there's no other person in a room, or having unusual thoughts, which could be to the intensity of called delusion, thinking that people are chasing you, after you, when there's no other evidence of that happening, and people around you are a bit puzzled when you start talking about those things, and you got that kind of reaction, so what you're talking about. So unusual experiences, unusual beliefs, and other features, but would be the main features of psychosis, for example. Bipolar disorder is also can be common. It's been popularized. A lot of celebrities have expressed that they are a diagnosis of bipolar disorder, for example. And the name bipolar means there's two phases, if you want, which is different phases of depression that alternates with episode of what is called mania or hypomania, which has, if you, in a way, the other end of the spectrum of depression, in the sense the opposite, where people, instead of being very sad and very struggling to motivate and struggling to find pleasure and struggling with energy, have lots of energy, are very elated, and everything is very positive, but to an extent that, laughing all the time, joking, meeting someone, someone who would usually, have their family, their work, or whatever, and then suddenly start to become very inappropriately over familiar with strangers, or start also spending a lot of money, because feel like everything's kind of like possible and affordable, starting to have many projects in an increasingly disorganized way, where actually all those projects never leads to anything. It's just ideas that comes and people, to the point that people can be very pressured in speech and talk a lot without it being very easy to interrupt. And their thoughts going very fast in their heads, and therefore the conversation being almost difficult to follow, is jumping from one subject to another. There can be also in some instances there can be some irritability as well, so people being much more easily frustrated and irritable than they would normally be. So both extremes of bipolar disorder, in the very severe end of depression or the very severe end of mania, there can also be symptoms of psychosis, such as delusions of guilt, for example. If someone's really depressed, they think that they are ruined, they don't have any money left, even though, again, their financial situation is not in relation to how they feel. Or on the other end, having delusional thoughts of grandiosity, like think they're here to save the world, or they've invented something that's going to save the world, which again is not in relation with anything that can be otherwise observed or discussed. So those, and in between the episode of depression and mania, usually the mood is stable and recovers. Other types we talk about is personality disorder. So that's characterized, personality disorder is characterized by interpersonal difficulties, usually when certain traits of personality become so pronounced. Again, you remember what I was talking about, sadness or any kind of emotion, anxiety is part of life, and therefore having interpersonal difficulties certainly is part of life. But certain personality traits became so marked, and the ability to respond to various interactions with the world or with people becomes in such only one way of interacting with the world that starts to create again a whole lot of problems. I've put there as well eating disorders, a very specific type of disorder, but that's the most common one, or the most known one probably is actually anorexia. So that's people who stop eating or really don't eat nowhere near as much as would be necessary to sustain their energy levels and their body, and that's actually a very potentially, when it's quite severe eating disorder like anorexia, is a very lethal disease. A lot of people unfortunately die of eating disorder despite all efforts put into that. So it can be quite dramatic. And the other side of eating disorder, which can often go together, would be bulimia, when people eat incontrollably vast amounts of food in a short time. And then, as I was saying, things are not black and white. So, very, very severe forms of anxiety disorder, even beyond the common mental that you would see most commonly, or very severe forms of depression, or associated with, together, or with bits of personality disorder, or with bits of psychosis, then that starts to become also something that would be considered as severe mental illness, or anxiety disorder that wouldn't improve despite all sorts of different types of therapeutic approach, be it medication or talking therapy or other approaches, and would, after months and months not resolve, then that could come into the classification of severe mental illness. And why am I making this distinction between common and severe mental illness? Because most common mental illness would be looked after in primary care, i.e. by GPs, by migrant services like talk changes, so that they would be under the remit of primary care, and GPs are really, really good and really well trained at identifying them, explaining to people, and treating them. Whereas severe mental illness usually would be addressed more by secondary, what you call secondary services. So it's a bit like if you have a problem with high blood pressure, you would see your GP, and they would be perfectly able to resolve that problem, give you some tablet for high blood pressure, for example, or advise you about your diet. So any kind of way of, improving your blood pressure. But if the problem with your blood pressure, or if you have a problem with your heart, then they would refer to a cardiologist. And that would be obviously something that needs more expertise, which GPs know a lot of things, but they cannot know everything about everything in detail. So those more severe mental illness, they would be more under the remit of psychiatrists or especially psychologists, and therefore we would call secondary mental health services. And that's East London NHS Foundation Trust mainly provide care for severe mental illness. That's already quite a lot of information around that, and really in a nutshell, like bits of what that could look like. And again, you could discuss all the diagnosis. I've added a couple just because they're a bit on alongside that we could put under neurodevelopmental disorders, because they are usually they arise during childhood or during developmental time. So for example, ADHD, which is very common and a lot of people talk about it these days, that's attention deficit hyperactive disorder, which usually starts before the age of 12, but can impact people throughout their life. And that's this, well, tendency to be hyperactive, but also in more impacting again on people is the deficit of attention, and that can obviously have lots of consequences academically. For example, if you go to school and it's impossible to focus because your mind focuses on millions of things at the same time, then obviously and if it's not picked up early enough, then obviously that can have consequences on people's trajectory academically, for example, but also relationship with their peers and so on. I've put also autistic spectrum disorder, and that spectrum of difficulties, which again are neurodevelopmental, usually starts during childhood and are centered around relationships with the world, with people. So having difficulties reading other people's emotions, having quite very specific focused centers of interest, are, for example, some markers that, again, not to say that in any way that those two traits would be giving you a diagnosis of autism spectrum disorder in any way, but it's just an example of how if it becomes very intense and happens all the time and defines your way to relate with the world, then it can create issues. And then learning disabilities, so that's mainly IQs that would be below what would be the average range, with consequences on people's functioning, and then also could have an impact obviously on people's life. And then one last bit that I've put there is also substance misuse. So that's difficulties with drugs, alcohol, prescribed drugs, or any kind of substance that people would start misusing or even become dependent on and addicted to, and so there's especially substance misuse services for this. So again, quick snapshot, but just to give you an idea about the range and what it might look like, but in a very brief way, and in no way, in a kind of like establishing a diagnosis way. Yeah, so all those elements are there, and that's how we kind of like look at it, if you want. So again, there's other diagnosis. Any questions about this? Again, that's very, very broad and wide. We can continue a bit further. So one thing I think with the awareness, I gave you some snapshots of some small vignettes, but I think one thing that, either the person or someone around them, a carer, a friend, a family member, there's obviously some change in presentation. So it's, depression, anxiety, something that appears that wasn't there before. So, oh, well, what's a bit different? Is a marker. So a change in presentation is very non-specific. Certainly starting to appear more sad than usual, or more anxious than usual, or look like someone's hearing voices suddenly. So again, all the spectrum. And then the impact on functioning as well is important, and that's one way. At the end of the day, the world is full of differences and different ways to go about the world, and things and thoughts and emotions. And so an important point is like, if there is an impact on functioning, and that can be obviously some suffering resulting from one of those symptoms, or the ability to engage with the world or fulfill whatever is meaningful to the person, not to me or someone else, but to the person, then this impact also contributes to lead us to believe that maybe there's something there that would need to be looked into, and therefore going and asking for help might be an idea. So where to ask for help? I've mentioned GPs already. They're the point of entry for the whole NHS usually. They're really well trained in mental health. It's part of their training, and as I've said, they are able to manage a wide range of common mental illness, even severe mental illness with some help. Talk Changes, well, you've heard about it, so I won't spend too much time on Talk Changes, but they have a really good website. There are obviously other points of call where you can ask for help. There's Dermond for the Turkish community, Beko Halim for the Orthodox Jewish community, who can be contacted and provide mental health support, both practical support, obviously advocacy, as well as talking therapy. All of them obviously being culturally informed. And then there's also a wide range, and I haven't put the list here because there's so many of them, of the voluntary sector providing really excellent support for mental health. And you can find, I've put the link here, you can find the list of a fairly good list on the Hackney Council website on hackney.gov.uk/mental-health. But that's also, a lot of those services take self-referral, which is why I've put them here in the voluntary sector.
Yes,
lighting up in the chat. Yeah.
Yes, we've got a question which I think will be useful to answer on that slide as well. What support is there for adults with neurodevelopmental disorder in Hackney?
Yes, that's a little bit later, but yeah, thanks for raising that. I'll try to make sure that's addressed. But yeah, I have something about that. Thank you. So where and how to ask for help. So what I've discussed was for let's say non-urgent situation, but in case of emergency, of crisis, mental health crisis, someone is in an acute state, in a state of agitation or incredibly distressed for whatever reason, gets the person or someone around them really concerned. There's a crisis line in Hackney, and I've put the number here, and it's free, obviously, and you can contact the crisis line 24/7. Saturday morning at 3 in the morning, New Year's Day, whatever bank holiday, weekend, during the day, during the night, the crisis line, there's a worker, or there's usually more than one worker on the phone. And as I said, the number here is free. There's also a crisis cafe, which is on the Homerton Hospital site in East Wing. It's called in a building called the Rabel Center, and that's open outside of the hours where usually other mental health services would be open Monday to Friday. Most mental health services would be 9 to 5 or 9 to 6. So it's open Monday to Friday from 6 to 9. Or during the weekend, they also cover the afternoon on Saturday and Sunday. And that's a place where anyone who feel they're in mental crisis, as defined by themselves, obviously, just like for calling the crisis line, can go, and there will be mental health specialists there who will be in an environment that's a bit nicer than a clinic room or A&E, and where you can go and have a cup of tea or a cup of coffee, but also talk through obviously what's going on and be advised about what's the best way to go about it. And obviously, in crisis, always for like for any emergency, there's A&E, so you can go to the Homerton A&E. But I would say, if it needs to be, then no hesitation if it has to be. But it's a busy environment. You have to wait, so it's not necessarily the friendliest environment when you're already in mental health crisis. Sometimes it's unavoidable, but that's why I mentioned the crisis line or the crisis cafe, because the crisis line is connected with other crisis services that can arrange home visits and so on. So if you can avoid going to A&E, it's always better. It's better for the system because it's already super busy in A&E. It's also better for people because they're usually in a less stressful environment. And as I said already, if you're in a mental health crisis, that's what you would like to avoid, being in a very stressful environment, very busy, very noisy. So that's where somewhere there in that list there is some of the a point around support for neurodevelopmental disorders. So support for severe mental illness in Hackney. So we have established in the last year some new mental health team in what now is called neighbourhoods. So all services in Hackney, not just mental health, but are organized around neighborhood. So there are 8 neighborhoods in city in Hackney. There's quite like, relatively small patches of 80,000 people, 100,000 people, habitants living around in the same neighborhood. And so each of those neighborhoods will have a neighborhood mental health team, which is closely linked with the GP surgeries working in that area. And they try to work really in an integrated way with the GPs, obviously, but also the voluntary sector that I was mentioning before, which is very, very rich in city in Hackney, with other services such as talk changes, for example, but also substance misuse services. So really trying to see, rather than having silos and different teams and different services and NHS services and non-NHS services working separately, trying to work together. So these are new teams that have been established last year that try to be as close as possible from home if you want. Then there's a recovery service that's for needs that are slightly higher, when people need a care coordinator and likely care for a bit longer than they will be in the recovery service. And then we have a range of specialist service, early intervention in psychosis, so it's people who experience a first episode of psychosis. Perinatal service, that's for people who experience mental health issues during the year before or after giving birth, basically, to a baby. There's a specialist psychotherapist with a range of therapy available. Specialist therapy, there's a rehabilitation service that's for people who have even more chronic and enduring difficulties. And a question, how do we know which community service are safe, quite you should signpost to? I'll come back to that. Yeah, I'll finish my few bits. So ADHD and autism service, that's one of the 2 small services in Hackney that offer diagnosis and support to people who have a suspected or established diagnosis of ADHD or autism. They offer consultation, advice and prescription about medication, and also advice about the impact the illness can have and how to manage it. And in the autism service, there's also, I think, a group of service users can kind of meet regularly and exchange how they feel, how things are, what works for them, what doesn't work for them. So these are relatively small services, and I'll come to that have a long waiting list, unfortunately, and have had in the past year or 2 at least. There's also, if it's for intellectual disability, then the integrated learning disability team, which offer support for people with intellectual disabilities. Crisis resolution and home treatment team, so that's the team linked with the crisis line. So if you're in crisis, it's a team that can try to basically avoid a hospital admission or bring the equivalent of the care you would get into hospital at home, so that obviously it's possible to avoid an admission, but it's not always possible. And then there's the City and Hackney Centre for Mental Health, which is the wards, the hospital, which is based at the Homerton site. And just to mention the Recovery College as well, which is a service which is structured as a college. So you can be a service user, a patient, a family member, a member of the public who's interested, and they run courses. Some courses are more around what is psychosis or how to deal with anxiety, but some are more about well-being and how to maximize your well-being. And all the courses are co-produced with members of the public or service users and professionals. And that's free and completely open. If you Google Recovery College Hackney, they're based in Primrose Grove and have a great program. Just to finish on accessibility, so we offer face-to-face or remotely, depending on people's preferences, but face-to-face is definitely an option. There are, for all the services I've listed, there's no waiting list except for psychotherapy, specialist psychotherapy, where there's a long waiting list. ADHD and autism spectrum disorder services, there's also a long waiting list. We're talking about a year plus wait. But all the other ones are accessible directly. We offer interpreter in person or over language line, depending on availability and if it's obviously face-to-face or a phone call. But similar to what Canaria was asking before, I've never encountered an issue with it. It's not a problem. If there's a need for someone interpreting, we'll find someone. as I've mentioned, there are some culturally specific services, such as Derm and Baker Holm that we work closely with. And obviously, it's a statutory service, it's the NHS, so any reasonable adjustment, whether it's because of learning disability or mobility issues and whatever, obviously we accommodate. So that's the end of my presentation. So I'll try to get to I've covered a little bit about and we can go more into detail about neurodevelopmental support. But Ella was asking, how do we know which community and knowledge service are safe, quality assured to signpost to? That's a very good question, because statutory services like NHS services we inspected by the CQC, and it's very regulated. So just like your GPs and so on. So you have that kind of like background that reassures you. For the voluntary sector and charitable organization, the one that are on the list of the Hackney website, the hackney.gov.uk/mental health, they are services which are recognized and known, because otherwise it's true. It's rare, but it's something to be aware. There are a lot of people out there who are waiting to take advantage of vulnerable people. If you're in a crisis, if you feel a bit vulnerable and you're desperate for help, then you might turn yourself to people who might, promise you that things are going to be fantastic within one day and ask you a lot of money. Well, if that's the case, then that should be some alarm bells. But my advice would be ask your GP, because they will know also the local services. And they'll be able to advise around that. Kanaya was asking, is the crisis line also available in all the languages? Yes, through Language Line. So they set up, if you want, a 3-way phone call with an interpreter. So that's yeah.
I think that's an improvement, because previously it was only available in English, wasn't it?
Sorry?
I think that's the crisis line was only available in English previously.
Yeah. I mean, obviously the staff there are mostly English speaking, but just like for any phone call consultation, we can fairly easily set up interpreter.
Okay, and maybe now we can take the last question, Oliver, because we have Dan Morgan also waiting for his part of the presentation.
Sorry.
That's okay. Ella was asking, is there anything being done about the neurodevelopmental waiting list, increasing capacity within the services, or anything else?
Yes, absolutely. Yeah, it's something that certainly we haven't been sitting and waiting for things to improve by themselves. So, but that's a very important point. Absolutely. Both trying to see how we can use our resources as efficiently as possible is one thing that we're doing, but alongside that is we're working to increase capacity in the service. Absolutely. So we've already brought in slightly more medical time. We would like to also add some extra psychology time and nursing time, but the main limitation to that in the last 12 months has been recruitment. There's a big crisis in recruitment in the NHS and in care, in health and care in general. And so that's been one of the limitations, which is why in the end, for now, we have extra medical capacity, because we're using that resource allocated, because we haven't been able to recruit nurses a nurse or a psychologist so far, but we haven't lost hope. So we'll continue with that. But there's definitely we're discussing with the commissioners about capacity within the service in general anyway.
Excellent. Thank you very much, Olivier, for the great presentation. I'll appreciate if you send this to me and I can pass it on to all who attended the meeting today. Thank you. And now, Dan Morgan, I'll let him introduce himself and talk about James's Place. This is an organization that I've never heard of before, and I was really excited to hear about the great work that you do. So please go ahead, Dan.
Thank you. Hi, everyone. I'll try and keep this as quick as possible.
Thank you.
Aware of time. So a little bit about us first and foremost. In the bottom left-hand corner is James. James was a student at Newcastle University He was 21 years of age. In 2006, had a minor operation, started to experience some thoughts relating to suicide. He went to a local walk-in centre. He wasn't offered any primary help there, referred back to his GP back at home. And within that week, he took his own life. His parents only received a letter to say he'd gone to the walk-in centre from the GP a week after he died. So that began a process, and eventually in 2018, James Place opened its first centre in Liverpool. As you can see, James's parents wanted a place where James could have gone himself within that specific moment of acute crisis, a place where men at that point could get help immediately and could be dealt with for the suicide crisis they were facing. And that formed our vision of who we are today. Our centres are, just as you can see in that picture, they're incredibly warm, welcoming. They're designed specifically to make sure that men feel like they're in a place of safety, that they can be cared for, and that they can be held. We really want to create an environment where men feel like when they walk through the door, this is their place for the next hour. You know, this is a place in which, as I've just said, they're safe and they're able to put across their issues to us in a way in which they feel comfortable to do. A little bit about us in terms of our access. So we support up to 500 men per year at full capacity. We can deliver up to 60 to 1,000 therapeutic sessions. It's quick access, there's no waiting list with us. We're professional, accredited and trained suicide prevention therapists. So it's a one-to-one talking therapy intervention with men aged 18 plus. I'll go into that a little bit more shortly. We have set up, as I've just said, our permanent London centre, which opened last month. That's in Bunhill Row, which is just off Old Street near to Moorgate. We're looking to open another 3 centres, so we'll have 5 centres in 5 years is the company aim. For that, you know, we want to ensure that eventually there's no man who's ever more than 2 hours away from the James Place Centre. That's our goal. We really feel that with some good fundraising, we're on track to achieve that. Who we work with, men aged 18 plus, that can be men who identify as male or anyone who identifies as male. We don't stand at the door and sort of keep our arm out and say anyone who's female or, you know, might identify different, would not be welcome at James Place. What we would say is that this is a model and an intervention which has been designed specifically for men in crisis based on statistics around male suicide and particular male suicide age ranges. It's men experiencing a suicidal crisis, so that incorporates plans, attempts, intense thoughts, or other risk factors. So we often get men who've had previous attempts, recent attempts, like we say, intense thoughts about ending their life, men who've lost the volition to go on and find hope for the future. Men who are able to engage and benefit from solution-focused talk and therapy. So people who have addictions under control, in a secure accommodation, no underlying chronic mental health issues, such as the need for longer term structured wraparound support. So things like, as previously been mentioned, psychosis or active addiction, we would have to take each referral in its context, but we would maybe look to another organisation or another service for that need, because we need people to be present in sessions. We need people to have the ability to work with us in a short, intense period. Men who are willing to work with us and consent to information sharing with GP and NHS. We ask for that on our referral criteria. So a little bit about our model. It's evidence-informed crisis resolution model. It's a psychosocial intervention. It uses the works of the interpersonal theory of suicide by Thomas Joyner, the collaborative assessment and management of suicide by Jobs, and the IMV model of suicidality by Rory O'Connor. we took the lead of Merseycare when we launched our Liverpool centre, Jane Boland, and she created a model for us, a bespoke model for men at this point of crisis. So the things that we look for, and when we're assessing somebody who might come to us, are we the right people to help you? You know, how can we help people get through the point in which they're at? Our job isn't to sort of take them from this level to right back down to a place where they can feel like they're, you know, fully integrated back in society. It's to get them to this point and out of the crisis. Our immediate concern is to get people out of that point, and then in a position where we can enable them with forward-facing tools and other, you know, organizations and services which can maybe help them in a more secondary or long-term, mid to long-term process. Our interventions almost, its sort of key factor is this set of cards that you can see. So we have a set of cards that we use with every man in every intervention. They're split into 4 segments and 4 colours, as you can see. And we use them at different stages of the intervention. So usually when a man will come to us, we will use the yellow cards, which are all about how the man got there. So it's mental, it's physical descriptives such as I can't sleep, or, you know, I've been harboring a terrible secret. And it's often things that men who aren't able to communicate, as we know, find another avenue in which to look at what might have brought them to the place where they want to take their own lives. So they'll be able to identify certain cards and say, well, yeah, I'm not sure exactly why right now, but that card seems to jump out. And then, okay, we can use that. A little bit further down the intervention, it's what's happening now. So, you know, what's there now, what's still there for the man, despite the fact that he knows he's going through this intervention with us. If someone isn't maybe developing in the intervention, we have the red cards, which is all about what's keeping the problem going. You know, why can't you sleep? Is it a financial issue? Where aren't you getting the support? And then more towards the end of the intervention, it's how I can get through this. And it's that all incorporates, you know, coping mechanisms. A lot of our work is around practical interventions. So we recently had a guy who was in construction. He talked about how he had a rope in the footwell of his van. And, you know, for 2 weeks, the therapist worked with him on how he could remove the rope from the van. It was as simple as that. You know, you remove the means, the access to suicidality, and then you work more and chip away at the more causation factors that are present. Just something I've missed out. Our work, as I've said, is intense, and it's quite short in terms of its intervention. It's usually around 6 to 8 weeks, and it usually lasts for around 6 to 9 sessions with each man. So that's how brief and intense the intervention is. That's the agreement that's placed between us and the service user. You know, we want the man to come in and agree that he's going to put the work in to identify what's happening and to remove himself from a suicidal crisis. We use a core scoring model. As you can see there from some of the scores, the average initial core scores that come into us usually come in at around 82. By the time a man's left us, that average final core has come right down. Its range has come down to a place where, you know, that average change means we can look at them and not say that they're in the severe bracket anymore. You know, it's not males who are at an acute risk of suicidality who are making active plans to end their own lives. We've usually brought them out of that crisis by that point. Our work is evaluated. You know, that scoring is professionally sort of valued by and assessed, if you like, by a professional body. We've had 2 independent evaluations of our work completed up to now by Liverpool John Moores University. They're both on our website, which you can look at, both there for viewing. So just a very quick sort of overview of what would usually happen. Man in crisis is identified, a referral is made to us. That can be either be a self-referral, a referral by a third party, a concerned third party, or a professional body like a GP or referral partner. A referral will be screened for suitability by a non-duty practitioner, and usually we'll offer them the man a welcome assessment. If we've got capacity, we'll try and get the person into the centre that day, but if not, it'll be within 48 working hours, and then we'll make an assessment on whether we're the right service for that person. Some questions below that we usually get asked: what happens to an unsuitable referral? When we won't just, return someone back, we will look for alternative referral pathways for that person, alternative services that we're aware of, that we work with, that might be more suitable than ours. We'll always try and find a way, another direction for the man. We won't just sort of say, well, we're not right for you, sorry, and lead them back into society without any help. We will always try and find some additional help. How quickly can a man be seen? Yeah, usually within 48 hours. We don't have a waiting list. What happens at the end of the treatment? Then we conduct a safety plan. We inform the GP that they've undergone a safety, an intervention with us. We offer the male alternative sort of ongoing care in terms of onward help. That could be therapy, that could be more nuanced care that we're aware of. We can refer them on to other organisations that we think are suitable. And where will the referral data be shared? Well, we inform GPs that the male's undergoing an intervention with us, but we don't really go into any more detail than that. Oftentimes GPs who refer to us, so they'll be well aware. If it's a referrer, we usually tell them too that the male is under our intervention. That I said, that usually lasts between 6 to 8 weeks, 6 to 9 sessions. Obviously, we're GDPR compliant and we hold all data securely that we obtain. To refer someone to us, you go to the Get Support section of our website. There's a button there that takes you through an online survey. As I said, we're available Liverpool, London. If you have a referral that you wanted to talk to us directly to in office hours, you can call that number for London. You can speak to a duty practitioner if you're not too sure about whether we're suitable or not, and have a conversation. But in general, I probably missed quite a bit out there because I'm mindful of time. But I'm just obviously here to answer any questions that you might have, or by all means email me with any information that you might need, and I'll be more than happy to answer any questions you might have that I can't answer today.
Thank you, Dan. Very, very useful, and once again, congratulations for running such an important organization. My very quick question will be, so I guess you can see anyone regardless of which borough they live at?
Yeah, that's right. I mean, we are focusing on certain boroughs within our locality. So we are focusing around East London, Islington, Camden, Haringey. But yeah, we will take referrals for the London borough. But to sort of work within the communities we want to work in, we want to sort of be quite focused within those areas because that's within the locality. And
so if needed, Hackney men can actually get support from you.
Yeah, absolutely. Hackney is one of the
Perfect.
areas that we're focused on. Yeah.
Excellent. Okay. Any further questions for Dan? Yes, no, I can't see any raising hand. Well, is 5 minutes past 5. So we'll end the meeting. Thank you so very much, everyone, for joining. Thank you, Dan. Thank you, Megan. Olivier had to leave. His apologies. I hope you find it useful. I definitely did, about talk changes and James's place as well. So if you have any questions, please, you all should have my email address. I sent you the joining details. Any outstanding questions, please pass them on to me. And I hope I'll be in touch with you within a week to send you the link to the YouTube video with speakers' presentations as well, where you'll find more details about the services they talk about, and any referral links and access information. Okay, thank you. Have a great evening then.
Thanks all.
Thank you. Oh, thank you, Ella. And thanks for the great questions as well.